In this session, we're going to be looking at some of the most exciting and certainly without a doubt, the recipient of the largest amount of funding probably anywhere in the world that has gone in specifically to male suicide prevention. I'm going to hand over to Professor Jane Pirkis and her academic friends, who are going to be giving us some insights into the. I apologize if I get it wrong, Jane. I keep getting this wrong when I say it. I'm going to take a stab at the Buoy project. And if I've got it wrong, I'm sorry.
No, it's the Buoy project. You're close.
Damn it! I'm so sorry.
There are all sorts of claims on different names. Okay. But thank you for the introduction. So just before I start, I would like to acknowledge the traditional owners of the various lands on which we're all meeting today and pay my respects to their elders past, present and emerging. And I'd also like to, because in this presentation we're going to be talking about suicide and male suicide specifically, I'd like to acknowledge all of those who have been affected by suicide, either because they've been through a suicidal crisis themselves or because they've had family members or friends who've died by suicide or felt suicidal. So as Glenn said, I'm Jane Pirkis, I'm from the University of Melbourne, and we've got this session is a panel session. So on the panel with me, I've got Kylie King and Stuart Vella and Tony LaMontagne and Zach Seidler, all of whom I know are here. I can see them all waving. Thank you all. So the way we thought we'd do it is that I would give a brief presentation about this project, the Buoy project, that we were fortunate enough to receive funding for. But I'll do it at a fairly high level. I'll give you a general overview of the project. The others aren't doing presentations. We thought it might be more fun and more useful to then just run it as a panel discussion. So I've got some questions that I'm going to ask the panel members, but I'll keep an eye on the chat, and the audience members are more than welcome to ask questions themselves, but perhaps I'll kick it off with the other panel members. So let me just share my screen. Hopefully everyone can see that. So we were fortunate enough, as I said, to get funding from the Medical Research Future Fund for a big project about preventing suicide in boys and men. All of the members of the panel are involved in the project, and a whole range of other people. It's been a fantastic exercise in bringing together a lot of people with a real interest and passion in preventing suicide in boys and men. So I've worked in suicide prevention for a long time, and if you have been around for a long time in the suicide prevention world, you can't help but be concerned about suicides by males because, as we were talking about in the previous discussion, they dominate suicide statistics. So 3/4 of all suicides in Australia are by males, as they are in most Western countries. And that's a statistic, but behind that statistic, that's more than 2,300 fathers, sons, husbands and brothers who are lost to us each year. And every one of those males has a ripple effect. There are people around them. So another way of thinking about it is that if the MCG was full of men and boys watching a particular sporting event, it was packed to the gills with boys and men watching a sporting event, within the following year, 20 of those boys and men would have taken their own lives. So that's another kind of stark way of thinking about it, I guess. So we and others have been very concerned about this and tried to think about whether there are ways of really making an imprint on this what is a really major problem. So we are obviously not the only people to have thought about the fact that males dominate suicide statistics. It's pretty bleeding obvious. And various brains around the world have thought about why this might be. So people have said things like males are more likely to choose lethal means if they're making a suicide attempt than females. They're more likely to use drugs and alcohol. So drug and alcohol use is a risk factor across the board, but but also drugs and alcohol are sometimes implicated in an actual suicide attempt. They're more likely to withdraw in the face of stress than females. There's evidence for that. And they're also less likely to seek help. So when I say less likely to seek help, I'm not saying that in any sort of pejorative way. And in fact, this is a large part of what our project is about, because it may just be that the services that are available just aren't well geared towards males. So they're not set up to encourage males to approach them. So those are all true. You know, there's good scientific evidence for all of those statements. But we started to wonder whether those reasons were sort of a little bit blunt and whether there might be reasons behind the reasons that might explain this dominance of males in suicide statistics. And I wasn't here for the whole of the previous conversation, but I know that there was reference to masculinity and masculine norms. So we've thought about the relationship between masculinity and suicide. And in fact, we've done quite a lot of work on this over the years. And when I talk about masculinity, and when the others in the panel talk about masculinity, we talk about it meaning the socially constructed gender ideal for boys and men. And we're absolutely not saying that there is one masculinity only. In fact, there obviously isn't. There are multiple masculinities. But I think it probably is still true to say that if you ask the person on the street to come up with some adjectives to describe the Australian male, they would use terms like stoic, able to provide for their family, take action in the face of danger, those sorts of things. So we've thought about it in that context. But as I say, there are multiple masculinities. So our project, which didn't have a name when it was funded, but it's become known as the Buoy project. So I'll tell you a little bit about it. And as I said, we'll get the panel to talk a bit more about their particular parts of it too. So as I said, we thought about this whole notion about masculinity and how it might relate to help seeking and suicide. And we thought about it specifically in the context of this new project, which is about how we might prevent suicide in boys and men. So we've taken this notion that there are multiple masculinities, but the dominant one probably is still one that promotes norms of self-reliance, stoicism, independence, and avoidance of negative emotions. So there are obviously different groups of males in the community, and within those groups, different types of norms might be promoted, but we think that those norms are still dominant. And obviously they're great in lots of ways. They're really positive. They can, they make a lot of sense in lots of contexts, and they're very helpful in a lot of contexts. But it also makes sense that they might run counter to boys and men seeking help if they're not travelling so well. And also importantly, when boys and men do seek help, it may not meet their needs, as I said before. So we thought a lot about that in fashioning the work that we're doing in this project. So we came up with this model, which I'm never quite sure how well this translates to a screen, but so we thought about this as the problem that we were trying to solve. So there are males in our community who are at risk of suicide, obviously, because we know that males die by suicide. A relatively small proportion of them seek help. A much larger proportion don't seek help. And we know that from various studies that have been done. Those who don't seek help, some of them may track along and come through their particular crisis. But a lot of them, unfortunately, probably won't, at least for that particular episode. And the likelihood of them having negative outcomes is higher than the likelihood of them having positive outcomes. So that's the lot that don't seek help. Of those who do seek help, probably a small proportion receive services that are appropriate to their needs, and a much larger proportion receive services that really don't quite resonate with them. So that group too runs the risk of experiencing negative outcomes. So this this very small proportion of males who are at risk of suicide end up seeking help, getting into services that really work for them and having positive outcomes. So that was the problem we started to think about. And it's a simplistic way of thinking about it. And obviously it's a model, but it sort of serves to describe how our thinking was going. So we thought about what might work as a solution to that, if that's the problem. So we thought that it would be useful to test some interventions or programs or activities or whatever you want to call them that do encourage help seeking, and do it through this focus on masculinity. So removing some of the stigma to seeking help, to putting up your hand and saying, perhaps I'm not traveling so well, that might be associated with those traditional masculine norms. So that's at the universal selective intervention kind of end, or another way of thinking about it is an upstream end. But then at this downstream end, there are indicated interventions that are really tailored to the specific needs of boys and men. So they're the ones that are about changing the way our services are delivered so that they do resonate with boys and men. So we partnered with an absolutely fantastic group, a large group, as you can see, of organisations that have an interest in men's mental health, men and boys' mental health, suicide prevention, or both. So we partnered with Tomorrow Man, Gotcha for Life, the Movember Foundation, MATES, Mental Health First Aid Australia, Victorian Men's Shed Association, Heiress Films, Every Mind, Lifeline, Mental Health, Suicide Prevention Australia, the Australian Psychological Society, the fabulous Australian Men's Health Forum, who we're here with today, and Stop Male Suicide. So we got together this group, and we started talking to them about how we might really build the evidence base about what works in male suicide prevention. And a lot of them, not all of them, but a lot of them were already running programs in this area. And we thought some of them might say to us, well, that's all very well, you fancy academics coming in riding roughshod with your fancy academic methods. We know our program works. We've been running it for a long time. We don't need you to tell us it works. But in fact, absolutely no one said that. And in fact, it was quite the opposite. People said, it's great, we'd love to partner with you. We'd really like to, we are very confident our program works. We really think it does good, but we'd like to be able to demonstrate that in a more formal way. So all of our partner organisations have been absolutely amazing, I have to say. So let me tell you about what we're doing. So we're running 7 randomised controlled trials, which is no mean feat, I have to say, but we've set it up so that different people are leading different trials. A lot of the trials are of programs, as I said, that already existed, not all of them, but a lot of them. And we've got our secret weapon of our fantastic partner organisation. So it's been really great. So Breaking the Man Code is an intervention that already exists. It targets boys in the later years of high school. It's run in schools, it's run in school settings, takes the form of workshops, and the workshops challenge some of those traditional notions of what it is to be a man. They were started by Tom Harkin, and Tom now has other workshop people who run the workshops with him. So the partners are Tomorrow Man and Gotcha for Life, and Kylie King, who's here, is leading that trial. The next one is Ahead of the Game. So again, it exists already. It also targets boys, high school age boys, but it involves their parents and their coaches as well. So it brings in some of the people who are around them. The setting for Ahead of the Game is sports clubs. Again, it's run through workshops, which again are all about thinking through how society makes boys, and in this case adolescent boys, think about what it is to be a man. So challenging some of the more traditional ways of looking at that. So there are workshops, and there are also online modules that go with that. Movember is our partner on that, and Stuart Vella, who's also here, is leading the Ahead of the Game trial. Mates, everyone will know Mates, fabulous organisation. So they have an existing program as well, and in fact it's grown over time. So it used to be Mates in Construction, so they used to run their programs on construction sites only, but they've expanded to be run in settings which are kind of male-dominated industries, I guess. So in this case, we're thinking about still trying to settle on which version of the Mates program we'll use, but it may be with men in the energy or manufacturing sectors, and on those kinds of work sites. And the format of Mates is an integrated program of training and support. So it's partly about challenging some of those masculine, how society imposes masculine norms on men, but it's also about providing support to them. Partner is Mates, and Tony LaMontagne and Tanya King are leading that, and Tony's here and we'll talk a bit more about that shortly.
Since the 27th of the 4th.
So the next program is called Conversations About Suicide, and this is one that exists, but we're modifying a bit for the purposes of the trial. So it's run by Mental Health First Aid, and they've been running it for a long time, but we're modifying it for use with older men in men's sheds. So we're working with Mental Health First Aid to just tweak it a bit so that it resonates more with men in those men's shed settings. The format, then it's normally run as face-to-face workshops, but during COVID, like a lot of activities, it's been converted to an online kind of program, and we're exploring the best way to do that with men in our context. So Mental Health First Aid and the Victorian Men's Shed Association are our partners on that, and Nikki Reevely and Amy Morgan are leading it. We're also developing from scratch a media-based male suicide prevention campaign, or some campaign content at least. So the target group for this is boys and men in general terms. So not quite so setting-based in the sense that it's not a setting, it's the community. It will be a campaign that employs digital and more traditional media, and Aries Films, who made Man Up with us, are creating the campaign content for us with help from Gotcha for Life and Every Mind. And I'm leading that with Simon Rice from Origin. And those first 5 are the kind of upstream programs I was talking about that are all about challenging some of those ways that society encourages boys and young men to think they should grow up as older boys and men, and encouraging them to seek help if they're not travelling so well. So those first 5 do that. The second 2, the last 2, the 6th and 7th programs, are at that other end, that downstream end, about making sure that services are appropriate to boys and men if they do seek help from them. So this is a new intervention that we're working with Lifeline on. The target group is male Lifeline callers, of whom there are fewer than female Lifeline callers. So that says something, and Lifeline has thought about this for some time, about just how, what kind of a fit males feel the Lifeline service is for them. The setting is Lifeline, it's the call service. And the format is yet to be finalised, but it's likely to include specialised training for the crisis supporters in male-centred messaging. So trying to make the service they provide for men and boys more appropriate to their needs. The partner is Lifeline, and again, Simon and I are leading that. And then the final cab off the rank is a program called Men in Mind that Zach Seidler, it's his brainchild, I have to say. Mental Health, which is a group of psychologists who provide services to specifically to males are involved as well. So Men in Mind exists already. The target group is men who have sought help through therapists who are in the market, in the business of treating boys and men. So this program, again, like the Lifeline one, involves largely training those therapists in a particular way. So there's a 5-module online and interactive training program that teaches them how to leverage particular therapeutic principles that are much better than average, I guess, in terms of understanding and responding to men's distress and suicidal thinking. And then we'll test the extent to which they've incorporated some of that learning from their training into practice, so in a few different ways. So Movember's our partner on that with Mental Health, and Zach is the trial lead on that. So there are 7 programs that we're testing, so it's quite ambitious. But we are hopeful. I like to show this picture at the end because we're hopeful that at least some of those trials that we're running may really help to boost the evidence base. So we'll have a better idea of what works and what doesn't work in suicide prevention for boys and men. So I'm going to stop sharing my screen, and I can see that I thought I could see that lots of chat had come through, but maybe I'm wrong about that. But what I might do is sorry, I'm just trying to look through the chat as well. I might start by asking our esteemed panel a few questions. So what I thought I'd start first of all by asking each of them just briefly to describe the program that they're testing. So I might start with Kylie, perhaps. Kylie, do you want to talk just a little bit, give a little bit more information about what Breaking the Man Code is all about?
Sure, I can do that. As Glenn pointed out, Tom Harkin will be speaking later in the Men's Health Connected series this week, and he's the founder of Tomorrow Man, and so he might be able to obviously speak in a more informed way about it than I can. But the Breaking the Man Code workshops are delivered to teenage boys in year 10 and 11 and 12 throughout Australia. They've already delivered hundreds, if not thousands, of these workshops, and they're reaching very large numbers of boys. The workshops take an interactive format, and so they work to obviously challenge boys' ideas around those sort of masculine norms and pressures they might be feeling, and I suppose the way that they're defining their masculinity, which is really important because we know a lot of that development of masculine norms happens in childhood and is crystallised in adolescence. So it's a really good time to get in. And also they're a really lovely organisation to be involved with because they take a really strength-based approach to the intervention. And so they do a lot of work with boys around sort of boosting protective factors that we know will go on and help them as they become young men that are protective against suicide, like, increasing their willingness and availability of social supports in their life, getting better at expressing how they're feeling and reaching out for help if they need it. So it's a one-off workshop, and they also, which we're evaluating, and they also do some longer form sort of workshops with school years too that might go throughout the year, and we're just evaluating that one workshop with them. So we're hoping to recruit about 40 schools. So we're in the process of that now.
Thank you, Kylie. Now, Stu. Oh, yes, I can see Stu online. Stu, would you like to talk a little bit about Ahead of the Game? Just describe that in a bit more detail.
Sure. Thanks, Jane. So Ahead of the Game is, as you've pointed out, Jane, a sports-based mental health and resilience program for young men aged 12 to 17 years. It's Ahead of the Game is the broad name for a number of programs which are delivered to both the young men, their parents, and their coaches. So for the young men, they receive 2 programs. The first we call Help Out a Mate. And Help Out a Mate is a basic mental health literacy program. It's delivered face-to-face, and it covers topics like the signs and symptoms, recognising the signs and symptoms of depression and anxiety, how to start a conversation with a mate about mental health, how to ask for help when you're not feeling well, because often don't feel great, and someone asks us how we are, and we tend to say, I'm okay, or I'm good, thanks. So how to ask for help when you're not feeling well. And then where to go to get help. It's quite interactive. We do a lot of role plays, and I often tell people that you haven't seen adolescent males giggle as much as when you try and get them to ask each other about their mental health. And I think that's normal, because it's quite uncomfortable for them. So that's one program for the young men. The second one is a resilience program. It's a blended delivery. So it's a workshop that they receive and then supplemented by 6 online modules. And basically through that program, we're just trying to get them we're trying to teach kind of the basic psychosocial skills that are going to help them when life might not be going as well as they'd hope. So accessing social supports, for example, and problem solving, understanding their emotions. They're the kind of things that are tackled in those modules that might help them kind of might supplement the mental health literacy information that we're giving them in the other program. We have a program for parents, and the kind of the core of the parent program is how do you tell the difference between what's, for want of a better term, normal, and what's potentially a warning sign of a mental health problem. So if you think through, when we say to parents, lethargy or eating too much, eating not little, changes in their behavior in that way, they say, but that's just my adolescent, that's them normally. And how do I tell the difference then between, that just being lethargic, sleeping a lot, and what's potentially a warning sign of depression? So that's kind of the core of the parent program, but we also teach them how to start a conversation with their adolescent, where to go to get help. And then for the coaches, it's very much along the same lines, but for coaches, the kind of the key message is you don't have to know what it is. You don't have to provide a diagnosis. You don't have to know how to solve the problem. It's not your problem to solve. What your role is as a coach is if you notice a change in behavior, if you just notice something, start a conversation. So start a conversation with the most appropriate person. That might be the adolescent, or it may be their parents. And that's kind of the core of Ahead of the Game. So we kind of come at it from multiple angles, trying to change that sports environment to be more conducive of positive mental health messages for young men.
Great, thanks, Stu. Tony, do you want to tell us a bit more about mates? And I think there's a mates session later in the program, but Tony, you've worked with mates for a long time.
Yeah, Glenn just put a note on that in the chat. Hi, everyone. I'm Tony Lawantani from Deakin Uni, and thanks for the chance to talk today. Apologies if I'm coughing and things. I got a bit of a cold. But mates started in construction, and as Jane has mentioned, has expanded to other blue-collar male-dominated sectors: mining, manufacturing, energy, and the basic. The core of mates, as Jorgen Billistrup likes to put it, is really to promote help offering as a way of turning sort of the masculine norm on its head. Offering help is from a position of strength as opposed to seeking from help, which simplistically is a position of weakness. So that's the core of mates. And the way that it works is there's an on-site training that's developed around a community organizing model of anger, hope, action to present some statistics and to present the suicide problem, which is elevated, in particular among blue-collar males, even among men, and to stimulate anger and then channel action. The action that they channel people towards is to talk to a connector. Connectors are people who get volunteers on sites, and they undergo a day or so of training, and then they're the person to go to with any question having anything to do with people in distress, a mate, yourself, anyone else. And that person's role is to connect the individual in need to the help that they need. It might be gambling, it might be alcohol, it might be suicidality, financial problems, whatever the case may be. And there's a range of supports, both through the employers, sometimes when there's an EAP, and mates programs, caseworkers, and services back up those other things that are available. And so that's the mates program in a nutshell. And it's really about promoting help offering as a way of enhancing help seeking. Thanks.
Great, thanks, Tony. And Zach, do you want to tell us about Men in Mind?
For sure. Hey, everyone. Sorry you have to see my mug again. I was in the last session, Jane. But, better repeated than forgotten. So Men in Mind is an online training program, that the first of its kind, that thanks to Movember's global reach, we'll start out with an Australian trial and then expand into our other markets in Canada, America, the UK, etc. It's really a nuanced way for therapists of all kinds. So I look at counselors, psychologists, social workers, mental health nurses, dietitians, whoever's on the call can give it a go. And it really tries to upskill them in what are best practice guidelines and male-friendly strategies for working with your male clients. So it goes through with very, nicely produced, I like to think, video examples of what this stuff looks like in practice. It gives you a lot of reflective exercises and really forces you to consider your own gender, the way that you were socialized as a clinician, to make sure that you understand the impact that that's having on your clients, and then starting to see, as we've discussed in the last session, strength-based masculinities, the idea about action empathy, the notion of trying to provide an understanding of suicidality and distress through a male lens. And our colleague Simon Rice has done a lot of work looking at those externalizing symptoms, which are, substance abuse and irritability and anger and this type of thing, which is considered men behaving badly, but is often a cry for help by many men. So I try to teach these things to the clinicians out there, and we just finished up a pilot with 150 clinicians, and I'm just sending through the link now for the trial, which is going to be coming up, so you can all sign up. But the idea really that we found, and the interest that we found is kind of astounding. And it shows, I did a curricular review of every medical and psychology school within the country, and nobody is talking about gender, full stop, whether it be femininity or masculinity. It's just not something that's spoken about. So we're trying to put it on the radar once and for all. And this, I see, I guess, is just the beginning. This is a 101 course. And hopefully through this trial, and thanks to Jane's incredible work getting this funding, we can, open up the door to get this into curricula in a more nuanced way, in all of its depth and diversity.
Great, thank you, Zach. So I'll sorry, hold on.
Jane's having a little canine control challenge. She'll be right back with us.
Sorry. I've got a dog that's gone deaf during lockdown. She doesn't do that very often anymore, but she's obviously just heard the front door. So I might ask, I'm going to ask Kylie and Stu a question, because Breaking the Man Code and Ahead of the Game are both geared towards adolescent boys. I wonder if you could both talk a little bit about how those, some of the more traditional masculine norms, and for that matter, norms more generally, get set and reinforced in adolescent boys, and how this might play out for them if they're struggling a bit.
Sure.
I feel like Stuart could probably answer that one better than me.
I can have first crack.
Okay.
But so my experience, my background is in sports psychology. My experience has largely been in working with young men through organised sports, and so we've obviously spent a lot of time in organised sports, and I see that the sports environment can very much reinforce the notions of that dominant masculine norms. So specifically this notion that weakness is bad, that and you should be tough, and to be tough you should show no weakness. To be tough you should be self-reliant, you should solve your own problems. To be tough, you should not ever feel sad or anxious. We've all seen, I think, ex-players or current players talk about, if you're injured, you don't show weakness, and I think that very much extends to mental health as well. This notion that you shouldn't show any weakness of any form in sport. Certainly, we've conducted probably hundreds of focus groups now, and just some of the things you hear coaches and even parents say about mental health is jarring at points. Coaches who say things like they have a mental health problem we just cut them. Like we're not, that we're not going to deal with that. I think that makes them too difficult. If they have a mental health problem, just we're better off without them. And when you hear those things, it's quite confronting. And parents too, who say things like, well, if they have a mental health problem, they just have to get on with it. They just have to deal with it because performance is the most important thing. And these are parents who are saying these things about their children, and it really makes you wonder the messages that they're not hearing from people who love them and care for them. So this is what, not all sports for sure, and certain sports have different environments where these things are more and less accepted. But I think adolescents who are participating in sport, these things are being reinforced. And we have some evidence to show that the more an adolescent thinks of themselves as an athlete, the more they engage with sport, the more that their identity is wrapped up in sport, the more profound the impact of the sports environment, for better or for worse. So, in my mind, this is the way that adolescents, particularly those who are engaged in sports and have an identity as an athlete, how these masculine norms are being reinforced.
Thanks, Stu. Kylie, did you want to add anything to that?
Oh, I was just thinking about, obviously, adolescence is such a challenging time, isn't it? There's so many different influences on young boys, from sports to schools to parents to peer groups. And I guess that's something we're going to try to understand through our evaluation. Is we've got a couple of PhD students joining us who are really interested in the influence of the school context. And there's, there's a lot of research around that tells us that, schools are obviously little social microcosms, and it's often where sort of masculinity is learned and played out, and, tussles for, finding your place in masculinity and in the various hierarchies, I guess, are worked out. So the context of the school is really interesting. And one of our PhD students is very interested in the context of family as well, and especially the role of fathers and how that works. And in fact, we were talking to some of the people from Tomorrow Man just last week about this, and they were saying, yeah, it definitely comes up in the workshops, and they'll have things like one of the exercises in the workshop is the boys paint their fingernails, because Tom and the facilitators challenged them about, who said boys can't wear nail polish, like where does this all come from? And they said more than once they've had boys saying, oh no, I can't put on the nail polish because my dad would freak. So yeah, so we're really interested in trying to understand more about that. And actually the learnings in that area are very, very early stage. So we're keen to explore them through the trial.
Thanks, Kylie. I'm just laughing because I got a message from the organisers saying that I was muted because of my Zoom customary dog problem, and I have to say my dog didn't do the second bark. She obviously made another dog bark. So let me continue. Tony, maybe I'll ask you. So it would be obvious to the audience from what we've all been saying that a lot of the programs that we're looking at are run in settings where boys live, work and play. Mm-hmm. How important do you think this is, like the setting-based notion, for the success of these sorts of programs?
Okay, thanks, Jane. Well, obviously we're driven to these places because that's where we can find concentrations of men and boys, and that's all well and good. But once you're there, what increases your odds of being successful? Well, there's no simple answer to this, but one element certainly would be the quality of connection between the people running the program or whatever it is and the people participating. And so in my work with mates, it's quite interesting. Their approach is, no, we don't want a professor up there talking about suicide statistics. We want somebody from the sector. We want someone from the same tribe standing up there, someone who's one of us, someone who is authentic, who is credible, and who probably has had experience that they can relate to. And that is, and the approach, having watched this, sitting in the crowd with the construction workers, it's been fascinating because it's clearly a quite an important element of the program, and I think it works quite well. So there's a huge amount of importance on trust and whether people can trust the information that they're hearing, or trust that if indeed they do reach out for help, they're not going to be shamed, they're not going to be revealed. And these things to a large extent have come a long way, but these are still worries amongst men, certainly in the mates context, and I'm sure in others. And there are various other groups, figures to bring to bear to speak to men and boys, such as the coach is an important. Stuart's just been talking about coaches. Young men look up to their coaches in a substantial way, I'm sure, as well as young women, and that's a very powerful position of influence. So, being where men live, work, and play is quite important, but more important than that is the content of the program and the way we attempt to connect and build trust and conversation with those men and boys.
Thanks, Tony. That's a good answer. So I'm going to ask Zach a question, then I'm going to throw the floor open if people have questions that they want to ask. And I've got a few more up my sleeve if people don't want to ask any further questions. So Zach, your Men in Mind program is one of the downstream programs. So it's not about encouraging boys and men to seek help. It's about making sure they get help that's useful to them and appropriate for them if they do seek help. I'd be interested to hear from you, because you have got lots of experience with working with therapists, as you say, of all kinds, but maybe particularly psychologists, in delivering this kind of male-centered care. How do the psychologists respond to it when you talk to them about a different way of operating?
Yeah, it all comes in the framing. And I think I've spoken a lot to this audience about the way that we are going to advocate for men's needs and men's, services in many ways, that we can't throw the baby out with the bathwater. We need to find a way to claim and suggest to these clinicians that they have the skills, the base skills that they need. And that's really the way that I sell this, is that this is just an extra 5% on top of the base skills that you already have. It's a nuanced adaptation in many ways to the skills that you've thought about. But often the main issue that I come across is the fact that clinicians believe that gender and masculinity is general knowledge. They think that they know it through and through because they live it every day. And what I always say to them is that they understand to an extent their own gender, whether that be masculinity or femininity, but they're really restricted to their own subjective frame. That they can only know what they know. They haven't really extended beyond that to try to understand how it interacts with others, what others' experiences have been growing up as a man or a woman, and how those might differ from their own. What really gets the buy-in is talking about the suicide rate and its links, especially within the research, to masculinity. And then I move towards trying to give them very practical, easy to use outcomes and strategies that they can employ in their everyday practice. Because I think that training far and wide often gets extremely semantic and really up in the air, and is quite hard to see how you're going to apply this. And I think that having had lots of non-clinicians as well actually go through my training, they've seen how it can apply in their everyday life with their sons and the men that they interact with. So I've had really, really good outcomes, as I just said in the pilot. We've had a lot of people suggesting that they're learning things that they've never considered before. And as I said, the fact that this isn't a part of any curricula, and the fact that no one is really learning this stuff, means that there's a pretty low bar, thankfully, for me to try to jump over, because it's not something that many people have necessarily considered before. And so even starting with the basics and getting them to reflect on, where they learned to be a man or a woman, where these lessons came from, who provided them these lessons, and why they continue to live, with some of them and have discarded others, for instance, has really gone down very well. And especially in face-to-face workshops that I've done as well, you get really vociferous debate around some of this stuff, and trying to link it back with your clinical work has always been really, it's been a really reassuring process, I think, for many clinicians to go, oh, there's a lot in here that I haven't considered. And it actually explains why this guy didn't come back. and it explains why this guy got better or whatever it may have been. My approach here actually links back with something that I hadn't considered previously. So it's really quite nice and heartening to see that clinicians are pretty open to this stuff.
Great, thank you, Zach. So I'm wondering if people in the audience would like to ask any questions. I'm having trouble following the chat because there's a lot of chat that's discussion rather than questions. So maybe if you do want to ask a question, perhaps put your vision on, so that, because then you'll come up on the first of the screens, and stick your hand up perhaps. Or maybe you don't have any questions. I can keep going. Hi, Andrew.
Hi, Jane. Look, one of the issues that I see repeatedly, and particularly when I've got a man at very, very high risk, he will have already seen a raft of psychologists and very often social worker, and very often the fundamental issue that's causing him to be at risk will never have been addressed by any of the mental health professionals. And that might be a police assault, it might be a family law outcome, whatever. And it's advocacy about those issues that then establish credibility with the man and enable me to assist him. And it won't be helped by mental health professionals. That's a statement, isn't it? Sorry.
So I think that's maybe a question for Zach, but I would just...
1 second.
Sorry, I think it's a question for Zach, but I would just say that my understanding of the kind of work that Zach is doing through Men in Mind is exactly about that. It's absolutely recognising that it's not just about the therapeutic situation. It's recognising the whole raft of influences that come into play in terms of how men and boys are travelling at any particular point in time.
I suppose we would say there, though, then the man is confronted by services that have been designed by women, for women, and are run by women, particularly in public health. So the man will go from having sessions with his psychologist to a panoply of services that actually don't fit him.
Yeah, Andrew, sorry, Jane, I'll just jump in.
Yeah, go.
I understand, and this is where this work comes in, is that I'm literally trying to upskill the workforce in trying to understand a male lens for responding to these guys, so that when they come in, they are offered a service that makes sense to them, that responds to their wants and their needs in that way. I don't necessarily agree that it's created by women for women. I think that, we know that psychotherapy as a base construct was created by two men in the grand scheme. Freud and Jung started this stuff, so you can blame them. But I think that what we should really be striving for is getting more men's voices. We need more lived experience. We need more qualitative interviews with guys to understand what it is that they need. The reason that women's perspectives are so ingrained within the system is because they are extremely vocal about it, is because they present, is because they're commonly within these systems, and the caring professions are dominated by women as well. We know that. So we're trying to get more men, to be psychologists and to be social workers like ourselves, as well as the fact that we're trying to get more men to talk about their experiences openly and honestly, so that we can learn from them and adapt the system accordingly. But there's no doubt that it's not working at the moment. There's no doubt that there needs to be shifts in the way that men are coming into these practices and are not told to conform to what is already existing, but rather that the system will conform to them. So we need to shift around our patients. That's what person-centered care is. You don't get, a man coming in to see a physio and the physio goes, I can't deal with that knee. That's just not on my, that's not something I've learned before. So we need to make sure that when the guy comes in, the system is ready to respond with something that is actually going to work for them. And first and foremost, it asks them what they're seeking. It doesn't just try to force something upon them. So that's really the basis of my training, is to understand men's expectations, their fears, what bothers them and what they are trying to achieve out of this. And then together in a collaborative way, we build out a strength-based goal program that is going to strive towards self-betterment rather than undermining their sense of power and control.
Zach, do you confront much institutional hostility to what you're trying to do? Because it's something over 30 years that I experience regularly. I remember being told when I did social work training and I tried to raise the issue of young men with eating disorders, and I was told in a lecture to shut up. We don't care if you, in brackets, men, or go away and die. That's the sort of thing that I can confront it regularly.
For sure. And thank you for sharing that. And I guess thank you that I get to stand on your shoulders in many ways, because I've experienced a bit of it, but I would say that in the grand scheme of things, I get widespread support. And that is thanks to the fact that everyone is kind of fed up with the status quo at the moment, and the amount of men that are taking their lives, and men and women alike are very clear on the ripple effect, as Jane spoke about. We've got thousands upon thousands of people who are experiencing the loss of somebody to suicide. And so therefore, I think everybody is starting to warm to the fact that something needs to change. Most importantly, when it comes to clinicians, they don't like feeling useless, to be honest. And what's happening at the moment is that too many men are dropping out prematurely. And so I get emails from male and female psychologists, social workers, hundreds of them every month saying, I think I need to do something differently. This is not working. So if anything, they are reaching out, and hopefully we're at a bit of a pivoting moment here where everybody is starting to go, something needs to change. So hopefully less adversarial responses and more support in the sector.
Yeah, I don't think it's impossible to do that. I'm approaching retirement now, and I can say that in 30 years of frontline work, so I've never lost a
Thanks, Andrew. I can see Mitch has got his hand up.
You want to get into a profession that's up against it in the public opinion department, I suggest getting into my line of work. It's a question for the panel. Just a slight tiny bit of context. On Monday next week, I've got to do a funeral for a 17-year-old kid. It's the fifth one in just over 12 months. Now, in my community, obviously you call it a suicide cluster, whatever you want to call it. Whatever it is, the feeling is that whatever we're saying, how we're talking to these kids, these young blokes about these issues is not working. So my question to the panel is, in your opinions, what have you found are the most effective methods of communicating, angles of approach, angles of attack, whatever you want to say, to get through to young blokes in particular, that this shouldn't be an option?
So can I, perhaps I'll give a quick answer and then I'll let the other panelists say their piece as well. I guess I'd say two things. I'd say that, one of the reasons that we've set the project up the way we have is that we don't want all of the emphasis to be on catching young boys and men when they're at the point of a suicidal crisis. So that's why so many of the programs we're testing are at that upstream end, so that we can try to avert boys and men getting to that point. So that's the first thing I'd say. And the second thing I'd say is that we did some work with Beyond Blue, with their Blue Voices group, which is a group of people with lived experience. And it wasn't just men, it was men and women. And we asked them about what had been the most useful thing anyone had said or done for them, most helpful thing when they were in a suicidal crisis. And the most useful thing universally was people listening without judgment. So it wasn't even so much doing anything active. It was almost passive, listening without trying to immediately solve the problem, and also not being being prepared to ask the question and not being too scared about what the answer might be, I guess. So I maybe that's a bit of a roundabout sort of answer and perhaps not quite specific enough, but I think everybody has a role to play in suicide prevention, and people who obviously there's a role for professionals, but there's also a big role for the people who are around these men and boys, and listening without judgment, I think, is really good advice. Can I just see if the other panel, I can see another questioner there, but let me just ask Tony if he wants to respond as well.
No, just very, very briefly. Yeah, I'm not sure, Father Porter, which community you're in, but that is an enormous thing to face. But in the same vein as taking an upstream approach, I mean, I suppose the thing that people crave is hope, possibility, opportunity. And that's a very much an upstream thing for a young person in crisis. That's perhaps not exactly what you need at that moment. But in terms of the long-term game, I think that's what it's about. It's about the social determinants. And if people can't see possibility, hope, then that's going to obviously be an enormous hurdle to get over. Not sure that's helpful, but it's just a couple of words. Thanks.
Thanks, Tony. Now, Spot. Oh, sorry, you're on mute, I think.
Oh, I just tried to unmute. That's fine. Hi, I'm in the Mid-Coast Coast Veteran Centre, and our approach when we do have a young veteran come in that is has the suicidal tendencies of that, we look at it very non-judgmental of that person, and the idea is to act as a peer support for that person, which is the main thing, is that you have to get his confidence, and then you sit down and talk, and then you move in different ways how you can help him, and that's constant. But we find that a lot of the stuff is not aimed at the male gender veteran. There's more out there for, like say if an AVO's been taken out, is more or less on the woman's side, but the veteran that is taken out on is probably the innocent victim. So we have to decide that when we sit down and talk to these guys, and it's very important, you know, as a peer support for them, is to understand what they're going through and to help both sides of the party to understand what he went through, such as he might wake up screaming at night, you know, ambush, ambush, or something like that. And the spouse wouldn't understand. She's frightened that something might happen. So we have to look at that side of things as well. So it's not an easy process. It's a long process. And the main thing is you've got to gain their confidence. If you don't gain the confidence, pack your bags and go away.
Mm. I think as you were talking, I was just thinking that a number of the programs that we're talking about, and in particular, I guess I'm thinking about mates, a lot of it is about that. It's about peer support and the recognition of similar experiences and what others have done in the past to come through.
Yes. Yeah, it's a great deal of understanding that you do give it. As I say, the older veterans, say going back World War II and that, they don't seem to have that response. I say with the latest, with Afghanistan, Timor, I did Vietnam, so it's not so much, but in the Afghanistan, Timor and that, the war is different. It's more or less where they have to go into the field in action with a camera sticking over their shoulder, making sure that they don't do the wrong thing. And someone pops up with a AK-49, whatever, 47, whatever, and then pops at him, but he might shoot first. And this have a response back in their subconscious mind later on after they leave. And we find that too when we're looking at in a thing like this. I don't know whether you can see it.
Sure, yep.
But that's what virtually a sort of gospel that we go by, to try and understand them as that. And that's that's how I think I've answered your question. And
Thank
another
you.
question that came up earlier about the males, young males. My grandson, this is actual. My grandson used to go to St. Augustine's College, I think it's St. Augustine's at Brookvale, and they didn't understand his mental health side of it. And his grades, very intelligent bloke, very athletic, plays 2 codes of sports. And he went down the hill, psychiatrist, all the rest of it, and being treated with various antidepressants. My daughter then changed him to a boarding college out at Campbelltown in Sydney. And he's now in the top 10 in his scholastic ability. It's a whole change because the people out at that particular place take the interest in that child. That's the biggest thing. Found out what he was wrong under his medication. They make sure that, and they treat him like a human being, just not like another person, number sitting in a classroom. So the change in this guy and his attitude is totally out of this world.
Yeah.
He's not aggressive anymore because the people took the time to understand him. It's St. Gregory's, it is at Campbelltown. They took the time to understand him, and they're constantly under this peer pressure, teachers, and they have that. So that's another real aspect that I've come up against. So,
yeah, thank you. And I think that's a consistent theme that that sometimes it does take a bit of time to find the, it's a bit like with Zach's work. Sometimes it takes a bit of time for a man to find the right sort of setting and source of help and groups around them. It's the same for boys. Yeah. I'm just going to go on to Tony Tony Webb, because I can see you're keen to ask a question, Tony.
Thank you. We've been doing a bit of work within some of the men's sheds and got a kind of an inner workshop going there. There's a couple of issues, but I'll come to a question. We've had quite a number of the issues around suicide ideation raised, particularly as a result of guys having held 30, 40, sometimes 50 years of silence around early childhood sexual abuse. But the question that I want to throw to some extent, it's helped by having within that group people realizing they're not alone. So it really reinforces that. But the issue that I want to throw to the panel is what is being done for the blokes whose kids have suicided. We've had a number of these, and it has been incredibly difficult for these guys to work through, the question, what could I have done? What should I have done to prevent this? What work is being done in this area with men as a way of, in a sense, trying to help blokes to work out what they could have done to prevent the suicide within their own families, and if they're unable to do it, how to resolve it for themselves afterwards and move on?
Yeah, and it's a good question, and it's there are some great services. There's some great kind of clinical bereavement services, but there are also some great services like Roses in the Ocean, which works with people who have been bereaved by suicide, not specifically men. But I guess it does raise the question, in the same way that we've been talking about whether some of the services that are out there for general services that are out there, whether they are going to quite work for people who are in a suicidal crisis themselves. I guess there's also the question about whether bereavement type services are exactly spot on for the needs of men and boys. And it's not just men, it is also boys who've lost siblings or boys who've lost parents. So it's a good question. Any other questions while I've got Hi, Samuel.
Hi, everyone. yeah, just introduce myself. I'm a PhD student at Monash, and I'm very interested in Indigenous men's health. And I was wondering, I guess, in your own projects and research, what considerations have been given for young Indigenous men, probably at 6 times the risk of suicide. So, yeah.
Yeah, and again, that's another good question. We certainly, as I said at the beginning, if you work in suicide prevention, you can't help but be concerned about male suicide because the rates among men are so much higher than they are among women. And the same is absolutely true in Aboriginal and Torres Strait Islander suicide, that if you work in suicide prevention, obviously it's a really important issue. We haven't got any programs that we're testing that are specifically aimed at Aboriginal and Torres Strait Islander males. And I think the reason for that is that, as I said, we're largely testing programs that already existed. So we sort of worked with a whole group of partner organisations to find out what they were doing and how we could maybe help build the evidence base around what they were doing. But I don't know, you may know more than we do about what is out there that is is up for grabs in terms of testing.
I've got part of my final module is specifically looking at Aboriginal and Torres Strait Islander men, Samuel. I must admit that I purposefully didn't do more than that, if that makes sense, because when you start to get into it, deserves its own course fundamentally. And I've had plenty of people reach out about working with gay, bisexual, trans men, for instance. And if I do more than a brief overview, it starts to kind of become disrespectful, because once you start delving into it and the magnitude of the issue, and you don't give it the limelight that it deserves, which is its own 5-hour course looking at social determinants within this specific community and why the suicide rate is as it is, and the co-design.
I tried to join this meeting that I'd booked in for the men's health thing, and I
Penny, I think you're on
just on the corner there, Grant.
There we go. So Zoom, it's a nightmare. So yeah, I think that's kind of how most of us view it. We've got incidental research, I guess, that happens within the Aboriginal Torres Strait Islander community, but we need to find a way to look at interventions that are specific for this community and actually research them accordingly as rigorously as we are the others. So sounds like you're going to be doing that, hopefully. So reach out to us. Let's work together.
Yeah, definitely do, Samuel. It would be great to hear about what you're doing.
I'm a clin psych student as well, so I'm pretty busy
love
as
it.
well.
Love it.
Excellent.
But I'll definitely reach out.
Get in touch with us and have a chat.
Yeah.
Kylie's at Monash.
Yeah, she's my supervisor.
Oh, she's your supervisor.
Yeah.
Plan to
Thanks for your response.
Everywhere.
So, other questions? So I'm conscious that we've got about 5 minutes left. So what I might do, rather than asking my own additional questions, is...
A question from Graham there, Jane.
Oh, sorry, I'm missing that.
That's all right.
Oh, sorry, Graham, I didn't see you. You're down the bottom of my screen. I missed you. Hi, how are you?
No problems. I was unsure whether I should ask one because I'm on the next session.
No, go for your life.
I can't help but ask, how did you select your partners in this process?
Well, it wasn't a scientific selection process, but we capitalised on some good connections we had already. So, for example, Kylie was already working with Tomorrow Man on breaking the man code. Tony's had long-lasting experience with working with mates. So some of it was that, capitalising on these good relationships we had already. Some of it was also driven by this notion of wanting to try to look at programs across the lifespan. So we wanted to make sure we were looking at some programs that were for adolescent boys, but also older men and everything in between. And we also wanted to make sure we had a bit of a gamut of settings, so schools and sporting clubs and workplaces. So it wasn't like there was an EOI process, anything like that. We also had to put it together fairly quickly, I have to say. But we tried to make sure that the different programs sort of sat together as a suite of programs.
Thank you. The reason I asked that is your first slide showed the real numbers don't get past the first arrow. So they're the susceptible ones, and then they go down the lower grade. That I was surprised there wasn't more emphasis on looking for people who are reaching out rather than collecting people who are reaching in.
Yeah, well, we have got the programs that are at that downstream end, as I said. So Zach's Men in Mind program and the Lifeline program. Yeah, look, it's a bit of a mix, I guess. It's an imperfect science.
Jane, I think, Graham, the reason that we didn't do as much for those that are reaching out is because the services are stretched. There's 6-month wait lists. There's only so much that we can look at in the current system. Hopefully come tomorrow when the budget comes out and we all get millions of dollars and we can do things differently, that'll be a different ball game. But beyond, the broad therapy space and then Lifeline that Jane and Simon are looking at, there's not enough going on within the space of men reaching out. We need a better understanding of what that looks like first and foremost before we can actually go and try to change the game there.
All right. What I'm going to do is invite each of our panel members to have a final say. So maybe perhaps I'll ask you all what the one thing you think could happen in male suicide prevention that would be a game changer. So maybe and I'll get you to try to be fairly brief with your answers. Zach, I'm going to start with you.
Oh, throw me under the bus. Okay. One thing that can happen. Well, I think this type of togetherness is essential. We need advocacy, really. And that means that researchers like ourselves, clinicians, plenty of people on this call, and then policymakers need to come together and share findings and reach out to the grassroots organizations as well that we've tried to pull in here to understand what works and then sell it to the world one way or another so that we can have a broad impact, because I think there is far too much splintering going on in this sector. Everyone's trying to get a little piece of the pie, and I think that with our powers combined we can do great things.
Excellent. Thanks, Zach. Tony, what would your game changer be?
Well, it's nice of you to make it easy and simple for us, Jane.
And I should say I did give my panelists a list of questions and I didn't put that on there, so it's a really bad one to end with.
Figured she'd save this one. Well, I'll just speak from my own sort of perspective. I'm a work and health researcher, and so my real interest is in dealing with the work as a social determinant of health. So giving people jobs that are rewarding, challenging, and promote self-esteem, inclusion. This is possible, but it sure isn't happening. So that's my perspective is from getting at the social determinants.
Yeah, that's a good answer, Tony. It's very upstream. That's great. Stu?
Jane, that's such a great question. I fear that I don't have a great answer. There are so many different ones running through my head, but I think of some of the core principles of ahead of the game, and one of them is just that these things are not necessarily individual level things. That requires intervention or programs or changing the social narrative, and so obviously we intervene at multiple levels. But I think for me, the game changer would be trying to change this social narrative and trying to really address the core issues, whatever you think they might be, in the places that they're structurally embedded in society.
That's a great answer too. I'm very impressed with all these off-the-cuff, excellent answers. Kylie, your turn.
I feel like I have nothing as clever as that to say, and it's all been said. But Yeah, I think just the recognition that, as we've all said, that, you know, suicide is a gendered issue and it happens in an gendered environment. And so I think just the fact that these interventions are all happening that attend to kind of unique context that men live their life is fantastic. And to pull all that research together. And of course, as Samuel drew our attention to as well, thinking about the intersections between different parts of people's identities and how that interplays with masculinity to bring about risk and protective factors for suicide.
Excellent. Thank you. I can see Glenn's reappeared to wind us up.
Yeah.
Thank you all.
Yeah, I tend to wind people up apparently. So that's obviously my job today. Jane, fantastic session. And to all of you, to Zach, to Stuart, to Kylie and to Tony, thanks so much. Really great to get an insight into this huge research project, which, as you all well know, is called the Buoy project, spelled B-U-O-Y. It only took me making the mistake twice and once in public to finally get it into my skull, Jane. I apologise. So just a quick question. So in sort of time scale, how long is this going to run for? When are we going to see the big results coming out of it? Are we going to see results?
The trials are staggered. So some of them will report much earlier than others, and that's dependent on a whole range of different things. But we've got 4 years.
Right. And how far are we in?
We're a year in.
We're a year in. Excellent. Okay, so watch this space. And you'll be able to keep us updated year by year as it goes along, I guess.
Definitely. Yeah, we're all happy to come back.
Fantastic. Thanks. It's been really interesting. You know, always good to get research, but so nice to have a whole research session which is so cohesive and fits, because it's designed obviously to fit together. It's very unusual to have a research project covering of this magnitude focused on male suicide. So thanks for all you've done to bring it together and for all your insights. And many of the different projects and the ideas that have been brought up in this session will be popping up both today, for example, the Mates projects in later on, and throughout the week, for example, the Tomorrow Man project being represented on Wednesday. So that's it, folks.
I just apologise. I was completely hopeless at keeping track of the chat, but do feel free to get in touch with any of us with questions.
Great. Thanks. Yeah, a lot of conversation going on, and it sparked a lot of interest and a lot of discussion. So just the beginning of a conversation, not the end of one.